In this presentation, I'm going to talk about a really big idea that I think would revolutionize how our department works, something I'm calling the Early Assessment MD. I'm going to follow the same pattern as I did in my last talk of describing the goals of this project, some of the barriers to implementing it that we'll have to overcome, and some solutions to these barriers. But first of all, what is it? Well, it's an idea that Brian presented at one of our rounds with a bit of a twist. Brian told us, about a year ago, about the Hamilton St. Joseph's Hospital ER process where a doctor sits up in triage. This allows them to see a whole ton of patients very quickly and, in the process, streamline the patient's care. The patient gets the tests ordered by the doctor in triage, as opposed to directives, and then gets reassessed by another doctor. The twist in the idea we're considering here is that the doctor who initially sees the patient also follows and makes the disposition for the patient. The difference is important because it's that continuity of care that allows us to call the initial assessment by the Early Assessment MD a PIA. In a nutshell, an Early Assessment MD will turn this picture, a diagram I created of our current flow pattern, into this, which is obviously much simpler and gives PIA primacy of process. The primary benefits to this type of solution are that our PIA will be measured in minutes, not hours. And there will be virtually no patients who leave without being seen by a doctor. This will mean that we have the best numbers in the province by a long shot. The current best PIA 90 is a bit less than 90 minutes, but this will cut that down to 20. As a result of this improvement, we'll receive a lot of P4R money, which could perhaps fund other projects we want to initiate. That's the big picture, but the secondary benefits to this type of process are numerous. Firstly, with a dedicated office, we are guaranteed space in which to work. Secondly, we also won't have to walk around as much to see patients. Thirdly, it will also most likely result in a reduction of lab work. And fourthly, for those patients who wait hours to be assessed and then have to wait more hours while they get a CT scan or an ultrasound, this will dramatically decrease these patients' lengths of stay. But if this idea is so positive, surely it's been tried before. Well, no, not exactly. As I mentioned, St. Joe's has a doctor assess the patient on arrival and a different doctor assess the patient later. But PIA requires that the doctor form a significant relationship with the patient throughout his or her stay in the ER. It's because of this rule that their PIA times aren't 30 minutes or less, like what I'm proposing we do here. Other hospitals have tried having a doctor in triage, but probably in the same manner as St. Joe's. All of these 3 EDs have since quit their triage MD program for reasons of space, resources, a lack of effect on PIA, and the efficacy of alternative solutions. But despite this this record of abortive attempts at a triage MD, I think it's worthwhile to do this because of the potential benefits and because of the slightly different tack that we're taking. Having thought about how we might enact this strategy, I've come up with 3 solutions. I'm calling them parallel and serial, and there's a hybrid option as well. The parallel option is the one in which the MD and the RN work together in the triage office. This option would yield the shortest PIA. It's also a good option for the reasons that the patient only needs to give his history once. I've heard frequent complaints about giving the history multiple times. And that we don't need to worry about finding space for a doctor to work out of. The major problem with this option is that the MD and the RN are tied at the hip. They have to work at the same speed, and constant interruptions like phone calls, ambulance arrivals, and reassessments would interrupt the flow of 2 people, not just one. There's also a shortage of space in these rooms, and any invasive physical exam maneuvers would have to be deferred until later. The serial option has the MD working in a space adjacent to the triage office and receiving patients after they finish being triaged. This allows the RN and the MD to work at different speeds and allows for a more complete physical exam. The difficulty would just be in finding that space and rearranging other spaces to accommodate. For example, we have considered using the lab area, but then where would the lab go? Also, there would be a communication problem that might arise. How would the nurse know if the MD is taking patients, or is overwhelmed, or is off doing reassessments? If the doctor isn't accepting patients at the moment, then what would be the indicator that the patient should get blood work and x-rays done while they wait? The last option is simply a hybrid of the first two. Since we have two triage offices, we can set up one with an MD and an RN working together, and one room with an MD and an RN working adjacent to each other. This might allow us to achieve the best of both options. For example, we could segregate cases such that patients who might require more invasive exams, for example abdominal pains or GI bleeds, go to the triage office that is operating in serial and have those exams done in privacy, while simpler cases go to the parallel room and get the benefits that I mentioned previously. So I've trialed the parallel option a few times now, and Laura Pitchinen has done it once, each of us for a bit less than an hour, and I'm going to speak briefly about how that went. I worked out of the triage office, the parallel option, with some good, fast RNs. All 3 times were when the department was pretty well under control, but triage was experiencing some moderate volumes, typical of the morning, the 5 a.m. or 8 a.m. shifts, or some weekend shifts. The positive outcomes that we saw were a high volume of patients, and several patients went home right away. Several other patients benefited from expedited imaging tests. Paperwork and charting, though, were a bit of an issue. From the patient's perspective, I think they had a positive experience as well. As I said in my previous presentation, PIA is the variable most closely correlated with patient satisfaction, so it's no surprise that patients enjoyed the very short waiting times. This particular family member whom I've quoted, whose daughter simply had a strained wrist, will probably have a conversation with her colleagues when she goes back to work to say how quick the service was. The next time her colleagues have to seek medical care, they might consider coming to the ER instead of a walk-in clinic, and this will increase our CTAS 4 and 5 volumes, which I mentioned as an objective in my last talk. So in theory, and from limited experience, the early assessment MD seems like a good idea. Implementing this type of strategy, though, will present some major hurdles that we'll have to overcome. The first is obtaining the physical space and material that will be needed. The second I've listed, and probably the biggest hurdle, will be the ability of the doctors to keep up with demand. Thirdly, we'll have to consider what to do with our learners while we work out of triage. Fourth, patients brought in by ambulance will circumvent our docs at triage, so we'll have to figure out a way to catch them. Fifth, compartmentalizing reassessments around the time that we're supposed to be doing early assessment will be a challenge, especially if we see a wide variety of presentations at triage. First, the easy stuff, logistics. I did this once on one knee, using the corner of the triage nurse desk, but having a stool was nicer. There is a lack of desk space in there, so it'd be nice to have your own. And Laura Pitchinen found that it would have been useful to at least have had some past medical history on a couple of her patients. So a computer would be good too, a computer of our own, that is. Perhaps we could solve all of these problems with a portable computer stand. In addition, we'll also need charts, stickers, order sheets, prescription pads, consult notes, and perhaps some minor procedure equipment, like for removing a nasal foreign body or suture removal. Of these items that I've just listed, charts and stickers might actually be the toughest to obtain because our current pre-registration, triage, registration system means that the patient doesn't have any identifying information when they come to triage. This sets us up for error by ordering the wrong tests and wrong treatments on the wrong patients. Obviously, that's a big problem. At the very least then, for this reason, we'll have to have identification stickers when the patient gets to triage. For the serial option, this won't be a trouble, since the patients will have all this printed by the time they come to us. For the parallel option, the patient won't have a chart printed because the chart includes triage information, necessarily done at triage. Perhaps we could use generic Beck charts, some other type of pre-printed chart, or just blank paper, as I've done in the past. Of course, with the parallel option, space isn't a problem. With the serial option, we'll have to look for rooms. Ideally, we'd have at least 2 dedicated rooms so that we could step back and forth between them, like in a family doctor's office. The lab would be ideal because it's right adjacent to the triage rooms, and we can put a divider so that we can have 2 patients in there. But if we choose the strictly serial option, then we'll need at least 2 triage rooms. So perhaps we could use 38 and 39 as well, with the chairs just outside the conference room. The question arises of where to put the lab then, and perhaps that would be in room 1, 22, or 14. As you can tell, this would inevitably entail a lot of work, a lot of organization. The second concern about speed is well founded. We really have to focus on matching supply of doctors to demands of patients very tightly. If a doctor gets behind and is delayed in seeing patients, then patients may as well get blood work and x-ray directives. But if we do that, then we're just back at the same system we came from. And if we have difficulty switching back and forth from the old system to the new system, i.e. doing directives before PIA versus having the doctor see the patient first, then patient care will actually turn out to be further delayed, and our times will actually increase. The importance of this is the reason why I'm presenting this graph again. We really need to close the supply-demand gap along the 2 axes, temporally and with respect to volume, by moving our midday doctors earlier and adding more manpower when needed. This will be really important for the early assessment MD to succeed. And again, as I mentioned in my last talk, the high degree of variability in our volumes will require a commensurate flexibility in our schedule. In addition to the changes I've shown here, we may even consider making the Hawk shift activation criteria include patient overflow. This will ensure that we maximize the responsiveness of our schedule and keep supply as tightly aligned to demand as possible. Apart from bringing in doctors when we need them, I think that this setup will help us achieve efficiencies that will speed us up. For one, in the parallel option, we can scribe in our chart while the nurse asks the questions. Alternatively, the nurse can scribe onto the computer while we ask the questions. And if we reorganize the charting system, we could actually have the nurse scribe the entire history, medications, past medical history, and perhaps even part of the physical exam. This will eliminate a lot of the charting time that makes up a lot of our total work time, as I showed from the time motion study data in the previous presentation, and make us a lot more efficient. Also, we won't have to walk around to visit all the patients, since they will be coming to us. Similarly, we won't ever be short of examination space, because this space will be dedicated for our own use. We can potentially forego signing up for patients if we have the nurses and ward clerks do it for us. And lastly, all of our assessments and all of our reassessments will be grouped, which will hopefully improve our flow. The one major lost efficiency is that since we will be dealing with a greater diversity of patients, we might have to cover more ground when doing our reassessments, walking from blue zone to red zone. Additionally, if our preliminary assessments are too quick and we discover later that we should have been hunting down a different diagnostic pathway, we'll have to reorder tests, which will delay care. But in summary, I think we can achieve appropriate performance speeds by redesigning the schedule and relying on intrinsic efficiencies in this system. Obviously, adopting such a system will change our relationship with our learners, the third concern I've raised, but I don't think it's necessarily prejudiced against them. In fact, I think it can actually improve their experience. I'm going to present 3 possible ways I think they could take part in such a system. Firstly, they could take their turn in triage, just like us, although we might need to consider an orientation and special training, or even restricting the practice to upper year residents who can keep up. Secondly, the students could reassess the patients we see in the triage office. This might not allow as much independence, but we can do a quick job and the students can perform much fuller histories and physicals so that they still have a contributory role. This also has the benefit of allowing us to see the patient before an inexperienced med student, so we have an idea of whom they're talking about when it comes time to review and whether or not the patient is really sick. Thirdly, students could just be responsible for patients that we don't see in triage. Their selection of patients might be a bit more limited though, and there would be the question of when and how they interrupt us to review these patients. Also, we could have a mix of these options, depending on patient volumes. When there are very few patients, see the ones we've already seen. When there are lots of patients, see the ones we can't keep up with. Fourth, an ambulance coming into the ED will be disruptive to the flow for an early assessment MD, simply because it bypasses the usual point of ingress at the triage desk. The first question we should ask is how disruptive our ambulance is going to be. Well, the average number of ambulances arriving per hour, in blue, ranges from 1 to 2.5 over the course of a day. This doesn't sound too onerous, but if the doctor has to leave the triage desk in order to deal with the ambulance, and it takes about 10 minutes to do so, that will mean 10 to 25 minutes outside the triage office. Additionally, you can see that the standard deviations on those numbers are quite large, often climbing up to almost 4 ambulances per hour, and the maximum number of ambulances arriving per hour in orange during the period that I looked at, from March to August 2015, ranges from 5 to 8. This could mean that the doctor spends the entire hour outside the triage office. So ambulance arrivals have the capacity to be very disruptive. We'll need to figure out an ambulance flow pattern that causes the least disruption to the early assessment MD. Obviously, with CTAS 1 patients, paramedics will take them directly into a red room and the patient will stay there. But with less acute patients, we could minimize disruption for the early assessment MD by putting them into Red 2, which is very close to the triage office, for assessment. After the examination is done, we can move them to the appropriate room where we have space. They could even be placed in the hallways if no room space is available, since the examination is already done. The drawback here is that, while it would minimize disruptions for the early assessment MD, this would mean that the patient has to be moved twice, causing disruptions for other workers. More than just minimizing ambulance disruptions, though, I'd really like to eliminate them entirely. This means keeping the early assessment MD in one spot. Some solutions to this might be that we have the learners deal with the ambulances, or devoting an entire shift, say the 11 a.m. shift, to ambulances, or devoting part of each shift to managing ambulances. Of these options, the first would make me a bit uneasy if I was in the triage office and my learner was anything less than a good R2. The second option might be so mundane as to drive doctors to tears, or overwhelmingly acute, depending on what type of cases came in. Probably the last option is the best option, starting off in triage for a couple of hours, then doing reassessments and covering ambulances for a couple hours, and then going back to triage. Fifth, and in a similar vein as ambulance arrivals, reassessments also have the potential to be disruptive because they take the doctor away from his station at or near triage, and they can happen at any time, depending on the patient's presentation and the speed of diagnostic testing. Ideally, you'd have a block of assessments in triage, then a block of reassessments, and then repeat that over the course of your shift. All of the reassessments would come up at the same time and fit nicely into the time slot in which you were doing your reassessments. In reality, that certainly won't be the case. These graphs show the average time it takes to reach a disposition decision from the physician initial assessment in minutes. You can see that there is a trend to shorter decision times in less acute patients and in patients who present as walk-ins as opposed to by ambulance. That said, the real story is in the standard deviation bars, which show how much variation there is in these times. So a decision on a CTAS 3 patient can be made very quickly or in a very long time. This means that grouping patients in a block for reassessment may not be feasible. Compounding the problem is the diversity of patients that we will see. Some patients might come up for reassessment quite quickly, say after a hand x-ray, while others might take hours, say after a CT scan. Also, since the patients one sees in triage might be placed anywhere in the department, more walking might be involved in the reassessments. Some potential solutions to these problems are as follows. First, you could have a schedule that isn't regimented at all, that you just come back to the triage office to do more reassessments when you're more assessments when you're available to do so. The problem here is that if multiple doctors are doing this, then we could end up bumping into each other. Second, the doctor could work as an early assessment MD just at the start of his shift, when there are no reassessments. After that, you could resume your normal flow pattern. This would still be useful, as a dozen or so patients would enjoy the benefits of an early assessment MD, and it would also eliminate the need to compartmentalize the reassessments later. This allows us to plan our schedule so that at most times there's an early assessment MD available and we're not bumping into each other. Thirdly, you can insist on a schedule that is regimented as to the time you spend in each area, but try to adapt to the inherent variability of ambulances and reassessments. You could schedule the ambulance assessment periods after an hour in triage with the idea that some reassessments will happen in this period too. Patients that are up for reassessment within the hour that you're doing triage will have to wait to the remainder of the hour. Or, if they are simple cases, they could come back through triage as long as they aren't too complicated. They won't be too disruptive. Lastly, we could have 2 triage streams. Complicated patients could go to one room and simple patients to the other. This would help group the reassessment times around the same interval, and we could do the simpler cases toward the end of the shift in order to avoid working overtime. Obviously, this is becoming a bit more complicated, and we haven't even started to consider the necessary overlap with other shifts throughout the day. This is all just hypothetical, and I think we'll gradually come to the right solution organically over time by starting with the simpler scenarios here and building on them, as opposed to a methodically planned top-down organization. I present these scenarios only as possibilities to get people thinking of the possibilities and envision how it might be carried out. I'm going to finish now by summarizing my presentation and making a short proposal for our next steps in rolling out this program. Firstly, I really want to reiterate how revolutionary I think this idea could be. As I said, if it works well, we could have the lowest PIA times in the province. Very preliminary experience shows some successes, so I think it's worth pursuing. In order to achieve it, though, we'll have to overcome some significant hurdles. The logistics will be relatively easy, but may involve rearranging the present pre-registration, triage, registration process. The schedule will be a bit more difficult, but we need to come up with better ways to match supply to demand, whether we do this early assessment MD or not. So I think we should get started on schedule reform. I presented 3 options on how to incorporate our learners into the process. Ambulances will have the potential to cause significant disruption, and I think we need to think of ways to minimize or eliminate that. And lastly, reassessments can also be disruptive and may involve more walking because of the diversity of patients at triage. But we can limit that by using a hybrid parallel serial system with 2 triage streams. So what I propose is that we all start trying out the most simplified version of this system now, when you have the time and inclination. It doesn't take much to organize, just a discussion with the triage nurse. I think the parallel option would be the best way to start because it's the easiest to turn on and off. And it's probably best to do it when the department is relatively under control, usually in the early morning shifts. In the meantime, I think we should work on simplifying and streamlining the registration system, as well as coming up with a better schedule with appropriate remuneration for call-in periods, in order to lay the groundwork for using the early assessment MD more frequently than just on occasion. Ideally, we gradually evolve, using it more and more frequently until all of our patients are assessed in this fashion. And lastly, we plan to have a rapid improvement event to discuss some of these ideas further with the nurses and doctors later this month. Hopefully, we can further refine this idea at our meeting this week and at the RIE. I'm looking forward to this discussion because I think this idea really has the potential to make us one of the best ERs in the province. Thanks.